Mary E. Miller, it is now your turn for public comment.
Hi, thank you. Can you hear me?
Yes, we can hear you.
Okay, my name is Mary Miller. I'm a retired occupational health nurse practitioner. I'm representing the Occupational Health and Safety section of the American Public Health Association, a diverse community of public health professionals that champions the health of all people and communities. We are providing these comments in hopes that we can improve infection control guidance for healthcare settings, last updated in 2007. Our comments concur with the feedback from National Nurses United and other occupational health and safety professionals. CDC and HICPAC must fully recognize aerosol transmission of SARS-CoV-2 and other respiratory pathogens while updating this guidance. It's essential that these recommendations align with the current scientific evidence regarding transmission mechanisms and best practices for protective control measures. CDC and HICPAC must maintain and strengthen respiratory protection for healthcare workers caring for patients with suspected or confirmed respiratory infections, including the requirement for N95 respirators and incorporating elastomeric respirators and PAPRs into updated guidance. The lack of appropriate guidance and resources for respiratory protection in healthcare settings during the COVID-19 pandemic led to uncounted illnesses among patients and workers. The California ATD aerosol transmissible disease standard is a good example of how to implement use of PAPRs effectively. I have more to say, but it's notable that OSHA and NIOSH are not included in this committee, nor unions and other worker groups that represent nurses and other workers, and these should be included in future committee meetings. CDC and HICPAC must use an approach that's consistent for all employers to follow, not just a crisis response standard. It must be an approach that is clear and explicit on the precautions that are needed in situations where infectious pathogens are suspected to be present in healthcare settings. There must be a standard approach that does not leave it up to individual employers to make their own decisions with little or no accountability. So I jumped ahead a little bit because I thought my time was already up, but we need to engage with other stakeholders more effectively, including those who are direct care health workers, patients, community members, and other public health professionals, including occupational health and safety, not just infection control professionals. Thank you very much for this opportunity. Let me know if you have any questions or concerns.
Brianna, can you read the next name?
Lisa Brosseuu, it is now your turn for public comment.
This is Dr. Lisa Brosseuu from the University of Minnesota, Center for Infectious Disease Research and Policy. I commend the committee for reconsidering the outmoded paradigm of droplet and airborne for infectious particle exposure, but I encourage you to think carefully about the air mode of transmission. While it is true that particle concentrations can be higher near an infected source, with time, the concentration of smaller human-generated infectious particles produced by breathing and speaking will increase throughout a space. Breathing in small particles near an infected person is risky, but sharing or entering a space with an infectious person can also be risky at any distance. Yesterday's presentation recommended well-fitting masks. While it is important to focus on fit, filter efficiency and breathing resistance must come before fit. No amount of fit will improve on a low efficiency filter, and no one will wear something with high breathing resistance tightly against their face. It is the combination of these three things, and in that order, from filter efficiency to breathing resistance to fit, that matter most. Respirators are designed to have good filters, low breathing resistance, and good fit. Face masks are not. I caution the committee to review the studies comparing surgical masks and respirators from the perspective of exposure to infectious particles, which is a function of exposure time and particle concentration. It only takes one unprotected exposure to be infected. If continuous wear was not required, then a study is incapable of evaluating the effectiveness of anything worn on the face. And finally, I strongly discourage any reference to a reliance on the ASTM barrier face covering standard. NIOSH proposed workplace performance barrier face coverings, but that was only for workers with lower risks, not working in healthcare settings, and only during the pandemic. Those types of barrier face coverings are not appropriate for any worker in a healthcare setting. Thank you for the opportunity to speak today.
Thank you. Brianna?
Dheerenda, Kommala, it is now your turn for public comment.
Good afternoon, everyone. Thank you for this opportunity to provide a public comment. My name is Dheerenda Kommala. I'm the Chief Medical Officer for ECRI. I have over 20 years of experience as an academic clinician, researcher, and a Chief Medical Officer. ECRI, headquartered in Plymouth Meeting, Pennsylvania, is a 55-year-old independent, not-for-profit organization committed to improving safety, quality, and cost-effectiveness of healthcare. ECRI has built its reputation on disciplined rigor with an unwavering commitment to independence, according to our founder's principles, Dr. Joel Noble. ECRI is the only organization holding dual federal designations as an evidence-based practice center and a patient safety office by the U.S. Agency of Healthcare Research and Quality. In January 2020, ECRI affiliated with the Institute of Safe Medication Practices, a global leader in medication, to form one of the largest patient safety organizations in the country. To date, we have evaluated 5 million critical patient safety events and near-miss reports. Furthermore, our team of clinical engineers conduct independent medical device evaluations with laboratories in the US and Malaysia. We strongly advocate for evidence-based infection prevention and control practices. ECRI has a team of infection preventionists, epidemiologists, human factors engineers, biomedical engineers, research librarians, physicians that provide a comprehensive approach to infectious disease-related issues. Our infection prevention control team, led by Dr. Erica Kalp, are certified subject matter experts on infection issues facing healthcare today. The IPC team has provided hundreds of proactive infection prevention control assessments and outbreak response mitigation efforts within a variety of U.S. healthcare facilities, from dental practices to ambulatory surgery centers to acute care. In consideration of our expertise and impact in the world of patient safety, infection prevention, and safe medication practices, I request the CDC HICPAC consider including ECRI as an active participant in the Vital Committee as a new liaison organization. Our presence will advance our mutual mission to promote the use of clinical evidence to guide practice decisions, along with the integration of human factors engineering to improve patient outcomes. ECRI will serve as an invaluable partner, and we stand ready to work collaboratively. Thank you for your time and consideration of my request for liaison organization status. Thank you.
Thank you for your comment. Brianna?
Kerri, Wizner, it is now your turn for public comment.
Hi, my name is Kerri Wizner, and I'm an occupational epidemiologist, and I'm representing the Occupational Health and Safety section of the American Public Health Association. I echo a lot of the things that Mary Miller said, that we need to maintain and strengthen respiratory practices for healthcare workers. When left up to employers, respiratory protection programs are weak, either due to a lack of resources or lack of understanding. If we could promote EHFRs and PAPRs into regular usage, we wouldn't need to adopt the crisis standard approach in this updated guidance. Like Paul Conway said, people need very specific guidance. Assuming the guideline is the best case scenario, likely implementation will not be followed precisely. I'm concerned that the direction of HICPAC is headed sets the bar too low and will mean more healthcare workers and patient infections. Actively engaging direct healthcare workers and their unions and patients and community members in the process to update infection control guidance is essential to crafting strong and protective infection control measures. And I hope that you guys will modify the guidelines based on the feedback that you receive from these communities. Thank you, that's all.
Thank you for your comment. Brianna?
Kavanagh, it is now your turn for public comment.
I'm Kevin Kavanagh from HealthWatch USA, and I would like to comment today on enhanced barrier precautions. I would like to echo the concern of the panel regarding these precautions. Enhanced barrier precautions are not taken for what is so-called low-risk activities, and residents are allowed to roam around the facility. Back in November 13, 2019, I voiced concern in a CDC public comment regarding enhanced barrier precaution effectiveness. The predicate data of these precautions does not fully support their safety. For example, low-risk activities such as passing meds had an 8% chance of contaminating gowns with MRSA, and that was with each activity. And these activities are performed so commonly, transmission will occur. This data was based on an article by Mary Claire Rodman et al. On May 26, 2015 in Infection Control and Hospital Epidemiology. EBP is advocated for use to mitigate the spread of CRE and Candida auris. These are highly dangerous organisms. A controlled clinical trial is certainly indicated before planning adoption, especially in non-research settings. And I would be doing online training for these precautions with extreme caution. A better approach would be to screen and identify the microbiome of residents, decolonize these residents, and if not successful, implement cohorting strategies. Admission and periodic surveillance is key to stopping MRSA in hospitals, in mitigating the spread of SARS-CoV-2, and in keeping nursing home residents and working staff safe. It is concerning that the CDC appears to be moving forward with enhanced barrier precautions where there is little supporting evidence of their effectiveness with dangerous pathogens, and is also at the same time considering abandoning strong recommendations for N95 masking when there is decades of occupational research supporting their use. Thank you very much.